Okay. All right. Thank you everyone for joining us today for our South Texas Regional Family Medicine Grand Rounds. Our educational partners today are the South Central Area Health Education Center, and our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Next slide, please. Thank you. Today is February 12th, 2025. And you can claim attendance for today's session via the code on the screen. Please text attend 1009-6245 to the number on the screen to receive credit by midnight. All right. American Academy of Family Physician members can claim credit for this activity online via the link on the screen. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the AAFP. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Next slide. Our family medicine grand rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. All right, and now Dr. Nato will introduce both our speakers today.
Thank you. It's a pleasure to introduce both of our speakers, two of our outstanding third-year residents. I'm going to introduce them both now. Dr. Varella is going to speak first, and then Dr. Huddle. So Dr. Brooklyn Varella is one of our current PGY3 residents. She received her bachelor's degree at Texas Tech University, as well as her medical degree at Texas Tech University School of Medicine. After residency, Dr. Varella will be working in an outpatient family medicine practice here in San Antonio with University Medicine Associates. Dr. Erika Huddle is from a small town in Northeast Texas, a town of less than 3,000 people. She graduated from Dallas Baptist University for undergraduate with studies in biology and chemistry, and she graduated from medical school at Ross University School of Medicine. She is currently completing her final year of family medicine residency at University of Texas Health Science Center, San Antonio. She is married to her high school sweetheart, and she is the mother of one, soon to be the mother of two. She is returning to her home community to practice family medicine when she graduates from the residency. So, Dr. Varella, are you ready?
Yes, sir. Can you hear me okay?
Yeah. Yes, we can.
Okay, sounds good. All right. All right, so the poem that I chose to talk about is the title is Long-Term Glycemic Control and Dementia Risk in Type 2 Diabetes. Here are our objectives. So we'll be talking about predicting and preventing cognitive decline in patients with type 2 diabetes in the primary care setting. We'll talk about how glycemic control, the variations of that can impact dementia risks in patients, and equip us with some evidence-based information to guide our management in diabetes glycemic control in older adults. And then talk about actionable insights in our clinical practice about this topic. So first about the topic, diabetes and dementia. Some things that we know is that compared to people without diabetes, people with diabetes have a higher incidence of all-cause dementia, including Alzheimer's dementia and vascular dementia. This is a very, dementia has high morbidity and mortality, and so we take that seriously, and we're seeing higher rates of dementia and with our patients living longer years. Both hyperglycemia and hypoglycemia are associated with decline in cognitive function. And in older adults, they have a greater risk for the incidence of hypoglycemia, as well as risk of complications from hypoglycemia. So this poem addresses the research gap of this question of what levels of glycemic control are associated with the lowest risk of dementia in people with diabetes, meaning what should be our goal to try to avoid of what A1C levels, glucose levels, in terms of preventing this complication of dementia. So the study objective was to examine associations between cumulative exposure to various ranges of A1C concentrations, associating that with dementia risk across male and female sex and racial and ethnic groups. It's clinically relevant because this is critical in informing patient-centered glycemic targets for older patients with type 2 diabetes, meaning how aggressive or lenient do we want to be with their A1C and preventing very hyperglycemic and hypoglycemic levels, especially in older adults where their glucose can be more labile. So something that we already have the guidelines on is so from American Diabetes Association, this is their guidelines among the topic of older adults and diabetes targets. So in older adults, meaning over age 65 with diabetes, if they are otherwise healthy and have very few or stable chronic illnesses, and they're intact cognitively and good functional status, also implying a good life expectancy over 10 years, then we should aim for lower glycemic goals, such as less than 7 or 7.5, just like the rest of our adults with diabetes, a good goal there. And time below the range of 70 of less than 4%. In patients in another category who have more intermediate or complex health with a more variable life expectancy, and possibly with significant cognitive and or functional limits, or frailty, severe comorbidities, and less favorable risk to benefit ratio with the diabetes medications that are options for them, they recommend having less stringent goals, such as A1C less than 8, and paying attention to those hypoglycemic ranges for a goal of ranges less than 70 to be less than 1% of the time. And then in the third category, patients with very complex or poor health, such as shorter life expectancy and more risk with diabetes medications that are options for them, they receive minimal benefit, so less benefit with the stringent glycemic goals. And so we should have main focus should be to avoid hypoglycemia and symptomatic severe hyperglycemia rather than the stringent glycemic goals. So that's what our current guidelines from the ADA are. This was from their 2025 recommendations, so very new. So this study was looking into that. So it's out of Northern California using the Kaiser Permanente group. They looked at patients with type 2 diabetes, aged 50 years or older, and it was a cohort study from January 1996 to September of 2015. So a 19-year study period, which is pretty long. And then the exclusion criteria, which would exclude the patients outside of those on the left, there's fewer than 2 A1C measurements during the study period. And then if they already had prevalent dementia at baseline, and then if their follow-up period was less than 3 years. So pretty much Kaiser Permanente is a very large group. In this, there was over 4,000 A1C measurements in total of the patients who were followed, and they wanted to make sure it was ones that had a decent follow-up and see. And so what we're associating is their A1C levels with the event, which the event is diagnosis of dementia of any type. And it was a chart review study in their EMR. And so a little bit more on the methodology. They followed these patients who met those criteria, and it was a cumulative exposure to different A1C thresholds. So they would collect all the A1Cs that they had in this time and categorize them by the units. So if it was 7 to 7.9, it would be in the 7 to 7.9 category. And then the outcome was dementia using any of the ICD-9 codes in the inpatient or outpatient encounters. So that was our event outcome. And then the analysis was a Cox proportional hazards regression models to associate glycemic exposure with dementia. And then they adjusted for variations such as age, race, ethnicity, baseline health conditions, and the number of A1C measurements. And then they followed them until either the end of the study or patient died, or if there was a gap of over 90 days of them not being in this health system or diagnosis of dementia. So a little bit about the study. And so there was over 250,000 total participants. And these were the ones that were not excluded. So everyone that was included, almost equal male and female, a little bit over more male. The mean age was 61 and a half years, and that's at the beginning of the study entry. And so they followed them. The study again was 19 years long. And so that's at the start, so much older than 60. And then the mean follow-up that they followed these patients for before one of those reasons I just discussed occurred was almost 6 years. And then the diversity of it at the bottom was 50% white, 17% Asian, 9.9% Black, 14.6% Hispanic, and 5.9% other. And again, Northern California was the demographic area. And so just a little bit more information about the study population. And so they also noted about diabetes complications. You can see of the severe hypo or hyperglycemic events, MIs, stroke, those things. And then the reason for the end of follow-up, usually it was more administrative than membership if that over 90-day lapse, and then death, and then dementia next. And then the age at dementia diagnosis mean was almost 80 years old. Okay. Oh, and then I also liked the mean A1C measurements was 11.6. So that's, pretty good data if you did them, twice a year. For a little over 5 years, that's kind of what that would look like. So I think a pretty good amount of numbers of A1C that they followed up in this period. So a little over 11. So here's the results. So like I said, so they categorized them by the units of the A1C. And because they had many A1C numbers, what they did was categorize them by what was the majority of their A1Cs at. And then, so that's your x-axis. And then your y-axis, the event is their dementia diagnosis. And so they call this a J-shaped curve. So the 8 to 8.9 and lower did not show an increased risk of dementia in the hazard ratios. Now, the 9 to 9.9 and the over 10s were significantly associated with increased risk of dementia, and especially a big jump for that over 10. So I'll just give you a second to look at that. And then you can also see on the less than 6, which we'll talk about a little bit more, that there was not improvement in the risk of dementia by having the majority of their A1Cs as less than 6. And then here is the same kind of data, but stratified by men and women. And so you just kind of take a look at that. Kind of the one difference is that on the 8 to less than 9 category, that women did have a little bit more risk, but still not statistically significant on the 8 to less than 9 category. And then they both had increased hazard ratio with the 9 to 10 and over 10. And also with the less than 6 did not, continue to decrease their risk for dementia. So a little bit more of just talking about the gender differences. To me, they were very similar. Again, that like 7 to 8 to 9 was where there was maybe a little bit of a difference for the men and women, but still over 9 and especially over 10 had significantly elevated dementia risk. Here's kind of the same thing. And so they stratified this by race and ethnicity. And so I think the graph A up top is what's most helpful. The bottom left and right are again stratified by race and ethnicity, as well as women on the left and men on the right. So in comparison to the other graph that showed the hazard ratios, so you can see again that once it goes to the over 10, there's a large increase in that hazard ratio of dementia in patients of all race and ethnicities. I thought it was interesting in the kind of navy blue color, the one that has the largest slope between the 9 and the over 10 is Asian. And so that had a very high slope there. And then in white was also a consistent slope from the jump from the 8 to the 9s and then the 10s. So pretty much in summary, all races and ethnicities did increase when it was over 10 and a little bit on that over 9 as well. But I think the most interesting ethnicity is the Asian because it goes down and then a very sharp increase from difference from the 9s to over 10. So kind of just what we discussed, similar patterns. And of course, further research is always more helpful. I think the method to kind of get more information here is to further correct for variables and look at that. So a little bit more, a different kind of table to look at the results here where they adjusted for different things. And again, so this is kind of how they categorized them into which A1C range they would be in, but also of what I'm going to talk about is the variability. So not just where the majority of their A1Cs are of having this correlation with the dementia risk, but also of how variable their A1Cs were. So in most of the categories of them being more than half, so like the 25 to 75 or over 75 in a range, also had a good correlation in decreased dementia risk. And then whenever it's more variable, that also shows to be an effect of maybe a little bit more dementia risk. So this is kind of a different way to more simply organize what was there. So when 75% or more time spent in the 6 to less than 7 had the lowest dementia hazard, and then next was greater time less than 8 was with a lower dementia risk. And then the most time spent over 8% was a greater dementia risk, and then 75% of the time over 10% had the highest dementia hazard, and that's 1.76. And this is also kind of with that variability. And so over 75% of measurements in a particular range had a lower hazard ratio, and then less than 75% in a particular range had a higher hazard of dementia. So this kind of goes with kind of what we know of our older patients have often more labile glucoses, and hypoglycemia is a big thing that we want to prevent. And so rather than being not just at a good A1C level, but making sure that their kind of extremes, their highs and their lows are getting a little bit more consistent as well. So in terms of guidelines, the study really kind of goes with the guidelines that are already there. Is that a 6 to less than 8% A1C is correlated well beneficially in the dementia hazard here. And this is for A1C goals of our more geriatric patients. And then over 10% in the over 9 decreased their dementia hazard by 5%. And so having just less A1Cs over 9 makes a difference. And then more consistency, less variability is also likely to decrease dementia risks. And so I think of just ways to keep glucose stable throughout the day, less fluctuating. So that could definitely come into like dietary changes, and that because that's where we get our real highs. And then we're using medications to lower because there's this high average, but then that causes opportunity for hypoglycemia, so more and more variability depending on dietary intake and that changing so much. And then also this consistent benefit across patients of men, women, all racial ethnicities. We saw these results. So in terms of the study, I thought it was a good study. Definitely using the electronic health records is able to give a lot of data and a good data on demographics, comorbidities, lots of A1Cs, and being able to see that variability. So I'm a fan of kind of EMR studies, and they had a large amount of patients. And so I think that that's really beneficial. And I also agree with their exclusion criteria to where they had, I would say, high quality patient data in there. And let's see, and then the follow-up after 3 years. So I also agree of just to make sure that they didn't already have a high dementia baseline at the beginning. And so I think that was good. In terms of study limitations or things that could be good for next data. So the age did start at age 50. And so going younger and a longer follow-up would be helpful, as well as some information in terms of how long have they had diabetes. And so did they have it since age 30, or did they just get it at age like 49 right before this study started? And then how does duration of diabetes have an effect on dementia risk? And then the variations in how often they're getting their A1C measurements could also change things and cause bias. So are they getting their A1Cs checked every 3 months or once a year? So that's one thing. And then generalizable, I think it's, fairly generalizable. I think we had decent diversity, but of course, in terms of geography, it is only Northern California, even though that is a large area. But if they could kind of do the same thing, but in other areas of the US and do the same study and bring it all together, that would be much better generalizability, as well as the younger age that I mentioned. And although they did talk about different variables, they didn't talk about some that we know also contributes to risk for dementia, such as smoking and obesity, as well as it would have been good to talk about the event of which dementia subtypes. So did these A1C ranges cause increase in all types of dementia or certain ones? So, and I think that's something that they could kind of extrapolate from the data rather than just dementia itself, as well as in their social history and vitals, could add this in and get more results in data based on their smoking and obesity. And then so just talking in terms of primary care, so it kind of continues with what we know of our goals. So we know that we can and should be a little bit more lenient in the A1C goals in our older patients. And I think this does two things in terms of talking with patients and management. One, early on is this correlation with uncontrolled diabetes and dementia can be something that we talk to patients about, and motivational interviewing as an additional complication. I know we talk about heart disease and renal failure and neuropathy, but kind of adding this in as something that we're trying to prevent can be good. And then kind of on the opposite end of knowing that really in terms of if we're trying to decreased risk for dementia, A1C goal less than 9 is a little bit more lenient than our usual kind of less than 7 or 8, depending on the patient, as well as maintaining stable glycemic control rather than having so much variability. And of course, individualized with the patient of knowing, their life expectancy, what's important to them, medication options, etc. And kind of just to bring it back to the American Diabetes Association recommendations is that this does align with that of saying that don't have to be so stringent. And in patients who maybe have less life expectancy, emphasizing preventing hypoglycemia and sustained symptomatic hyperglycemia. Kind of already talked about this in terms of analyzing the data. And so the causal relationships, a little bit more specific about what dementia types, more diverse populations, et cetera. But I think they had great methods for the research. And here are my references. And the one in bold is the study that the poem is about, the one at the bottom.
Brooklyn, this is Dave Cotterndall. I want to thank you for a nice presentation, but I have one concern here, and that is, how do we know that the relationship they found isn't because they were more likely to screen for dementia in people with either high levels of A1C or highly variable levels of A1C that might have also produced cognitive complaints?
Yes. I think that's a great point, and that could definitely be a bias that, that I didn't even think of. And you're right, of patients with chronic conditions like diabetes, concern for dementia is going to be more, in the back of our minds, and maybe look into it more seriously. So I think that's an excellent point. But I didn't see them talk about that or address that in the poem or in the study. But I definitely agree. Of like that, not sure exactly what kind of bias is called, but kind of like provider bias or just like comorbid conditions. So you're kind of thinking of it more.
All right, thank you, Dr. Varella.
Thank you.
All right, let me pull up our next presentation. If you don't mind stopping me, thank you very much. Slide. And you can advance with the keyboard here. Okay.
All right, thank you. So my presentation is focused on exercise for initial treatment for depression, which I thought was interesting because I myself like a more holistic, more conservative approach with myself as a patient and as my patients as well. So I thought this would be interesting to dive into. So I like to start off presentations with the main idea or the main picture because sometimes I can get lost in the weeds. But the main idea for this is this study wasn't just focused on having a counseling session with the patient, saying, oh, you should do at least 30 minutes of exercise 5 times a week. It was actually physicians or other prescribers giving patients a prescription for exercise that was specific. And it was specific on frequency, intensity, duration. And then this is showing that it did show improvement in depression. So at least for my objectives, there's just 3, but really just to understand the study that the poem focused on, and then able to prescribe a specific exercise for your patient, and how would you even go about doing that? And then the third is how to create a measuring tool for yourself as a clinician to see if that exercise is even working for the patient, or if you need to do adjunctive therapy on top of that. So why is this important? Patients, they may be more interested in a more conservative approach. Maybe they are concerned about polypharmacy, or you as the provider are concerned about polypharmacy. You may have an elderly patient, who's already on like 13 medications. So the last thing they want to do is to start something else right away, at least as at the very beginning. Or you have patients who may be pregnant or breastfeeding, and even though SSRIs, there's a few that are safe with those conditions, they may still just be a little reluctant to start anything during those phases in their life. And also there is the stigma of mental health, and that's anywhere you go, whether that's rural or inner city, where starting a medication actually puts a name on it for them. And maybe at least leaving the clinic with something in their hand as far as a prescription for exercise would help them be more adherent versus taking a medication, perhaps. So one of the background articles, kind of what stimulated this one, and this was an earlier one in 2015 that NIH did. They were looking at it way more scientifically, but they were actually studying markers, IL-6 and TNF-alpha, to see if those rose up or declined with exercise. And the goal was to hope that they would decline, because that would show that those inflammatory markers were not as reactive anymore. But the study wasn't that great because, as you know, both of those markers can be elevated for other causes in the body, whether it's infection or just stress. So that study was definitely considered early stages. But I liked one point of that article, and the main point of it was that treatment of depression with exercise can work, but it also depends on your patient. And it's best to try this on patients that you think are prone to respond. So we can get into that later on. So what do we already know is, in general, we know that exercise is good. In general, we know that it's good for cardiovascular health. We know that it's good for preventing osteoporosis, but we also know that it can be good for mental health too, including depression. But what this study is supposed to help point out is that there's a lot of different exercise techniques that have been shown to help patients, not just one area, not just walking or not just strength training, but yoga or Tai Chi or Qigong. And then they also found that the intensity of the exercise actually showed more improvement in depression versus a more mild, light activity with the patient. So the poem article, that's just the title there that we already talked about. But this was the design of it was a systematic review and a network meta-analysis. So it looked at 218 studies and about 495 unique arms, which just means that it wasn't just looking at depression being treated with exercise versus an SSRI. It was comparing against a lot of different interventions. And there was about 14,000 participants as well. So the methods was the screening that they did. And then the active controls was usual care, which they said in the article was SSRI, a placebo tablet, or what you'll see in a little bit whenever I have the case intervals pulled up. They also compared it to cognitive behavioral therapy alone, or actual just exercising itself or stretching. They had one option, so we'll get into that too. But those were the databases that they used. And eligibility criteria was very broad. It was any participant that met the clinical cutoff for depression, and they used the Beck's depression rating scale, and they wanted the patients to score above 13. And the dates, so it's very relevant or very recent, 2018 to 2023. There we go. There's the eligibility criteria. And what's interesting too, is that they included patients of all physical comorbidities. So that's good and bad, which we'll talk about that too later, but they also included patients with arthritis, with diabetes, hypertension. There was no exclusion criteria with that. And here's some of the controls. So the SSRIs, cognitive behavioral therapy, and then the placebo tablet that we're talking about, and then the stretching as well. And then also kind of important to pull out was the educational control. So they talked about that mainly just the physician counseling about it. But exclusion, so they wanted this intervention definitely longer than a week. So they excluded any study that was very short time span. And they defined exercise as planned, structured, and repetitive bodily movement done to improve or maintain one or more components of physical fitness. So that's a very broad definition, indeed. And then, yes, it talked about the frequency, intensity, and type. And then most important is that they calculated the MET per activity, which was how much energy was each patient expending through this activity. And this was the network geometry that they came up with. So as you can see, a lot was compared between active control and the mixed aerobic exercises. But then you can also see there was some correlation from active control, if you look down, going towards walking or jogging, or across again, mixed aerobic exercises, down back again to weightless control. Then kind of up again, active control to strength training. So even the smaller, thinner lines, not as many studies were done there, but they had some comparisons as well. So definitely a very broad picture. So here's the confidence interval. So a more negative range is better because that's showing that 95%, you're 95% confident that by doing this activity, whether it's dance, walking, jogging, cognitive behavioral therapy, yoga, or the exercise and the SSRI, all those activities, that you're confident that it's lowering the risk of depression. Now, you don't want confidence interval to cross the number 1. So as you can look down towards the bottom, just physical activity counseling, that's kind of getting more the positive end. So that's not great. And the weightless control is not great at all, but that's okay because that was one of the controls as well. But as you can see, dance did very well, but the only problem with that one that they mentioned in the article was that the sample size wasn't that great. There's only 107 that they did there. But other sample sizes that were larger, like the walking and jogging, about 1,200 that had good results. Yoga, they're about 1,050. So some of those that had more results are a little bit more accurate indeed. So the results in general, they said were walking, jogging, yoga, strength training, dancing, all of those showed that it did decrease depression. But they did notice a trend between yoga was more effective in older adults and strength training was more effective in younger adults. And that makes sense in general too, with being more able to lift heavier weights or actually even just being interested in that type of exercise kind of fits with each patient population. So here's the confidence intervals between those in particular, the yoga and the strength training. So as again, when the confidence interval is becoming more negative, that means that we are seeing that it's lowering depression. So that's better. So as you can see with the age getting close to 70, 80 years old, that confidence interval is going down. So that's what showed that that helped more. And in strength training, the X and Y axis markers aren't on there, but towards the further end or the closer end with the younger age, you can see that strength training is more negative at the very beginning. So that would be more helpful in the younger adults. And then here's, which I thought was interesting. This was the MET. So that's what I was talking about earlier, the metabolic equivalent task. So this is how they're measuring how intense the exercise was. So as a example, they did walking versus running. And as you can see, it has that negative slope again. And on the x-axis is the METs. So the greater the MET, the more effect it had on lowering depression. So the more vigorous or more challenging the exercise was, they actually saw greater benefit, which was interesting. Now, this study was definitely had lots of biases. There was publication bias that they alluded to, and the researchers themselves were seldom blinded to the participants or staff, so there was bias in there too. So definitely was not a perfect study. But they did recommend in future studies that please conduct this research again, and please, try to find studies where they are blinded, or start, your own study where both the researcher and the participant can be blinded. And they also didn't break up the results on age or ethnicity or gender. It was just very broad. So I don't even have that data to give you, which is good and bad, because it's good because it was a good first type of study, but bad because we don't really know exactly how that differed between each group. But all in all, their conclusion was this has helped to bridge the gap from first-line intervention for depression, reduces stigma associated with seeking depression treatment, helpful in areas of low resources, and then it can be very individualized too. And the most ideal situation would be where you have a behavioral therapist with you. So BHC would be wonderful in conjunction with physical therapists and you as the provider. That would be the most ideal picture. Because as you can see on the confidence intervals, the one where it had SSRI and exercise and cognitive behavioral therapy, it had a greater improvement of depression. But exercise in itself just has benefits beyond just depression benefits. So obesity, like we were talking about earlier, cardiovascular, joint health, osteoporosis, osteopenia. So basically the article is saying that a prescribed exercise of any kind that fits the patient is going to help regardless with depression and or other comorbidities. But this is my personal analysis. Again, I've alluded to this. I think it was a great first line dip into the topic, but a little too broad, didn't break it up into different categories of gender, age, ethnicity. And it did not truly answer the question. I read it a couple of times just to make sure I didn't miss it. Did not truly answer the question of duration, frequency, etc. of the exercise. But in a way, which I'll get into, we're going to talk all about this in a second, but it allows us as the prescribers freedom to prescribe what's best for our patient. So in a way, thinking about it, if the study had said, we found the greatest, decrease in depression in patients within these studies that ran 5 miles a day within, a 2-hour time block, or they lift double their weight 3 times a week. That would be a little defeating if you had a patient, a sweet 79-year-old lady who has osteoporosis, she just had a hip fracture. Well, that would be a little defeating if you saw this study and said to yourself, well, I can't include this patient in this type of treatment because it won't benefit her. Whereas this is broad, yes, but it also shows that there's different categories that each patient could benefit from, whether it is just walking or jogging or yoga or Tai Chi. And the other thing is that it did not truly answer how it rated depression afterwards. After the intervention, I'm assuming they still did the Beck's depression scale to grade it, but it still wasn't very clear on that either. So in a way to take from that with this article is that also kind of gives us the freedom to develop our own screening tool if we want to see if these interventions are helping. So this is kind of where we talk about how to apply it. So this would be to develop the individualized exercise plan based on your patient's interests, the most important, and their limitations, which is also very important. And just like you would prescribing a medication, start off low, start off slow, but definitely feel free to increase the intensity because as you saw with the MET confidence interval, it did improve the amount of depression, if you will, with the more vigorous exercise. So what I thought as an example, this would be a good QI project actually in the future in your own practice, is that you could conduct a PHQ-9, that's what we're most familiar with here, at the beginning of your intervention. So just as a good baseline to see where you're at. And then you can use that PHQ-9 after each time you follow up with the patient after you've already prescribed the exercise to see if it's improving, if it's not. It's more of an objective measuring tool. But then I thought another thing you could do is have a survey where the patient can answer if that exercise is still stimulating to them. Is it still interesting? Would they like to increase their frequency intensity? Kind of gauge their own perspective. And something I didn't put on the slide, but I think would be good is definitely ask about their adherence to the exercise. That's definitely the most important. So we'll get into that in a second, but yes, so how would you even prescribe exercise? So there's what's beautiful about this is you have the freedom. You are the provider. But here's just one example. I know Dr. Sood shared with us this resource a couple of weeks ago, which I thought was great, which I'll talk about in a second. But before we even dive into this resource on the screen, for instance, if your patient was chatty Miss Kathy, and she's coming to you and she has depression and she's like, Doc, like I don't want to start a medication. I already have 10 meds, maybe later if it's not working, I'll try it, but what else can I do? Okay, well, let's try some exercise for you. Now, would she do well on a treadmill by herself 3 times a week in her basement? No, I mean, that's just not her personality. She wouldn't do well. She would do well. I mean, of course, you would ask them for sure, but I would give them maybe 2 options to limit it. But she would probably do well in a more group-based activity like Zumba, something with dance where there's laughter, there's endorphins being released. One example there versus you had one patient who's a retired veteran. He wakes up at 4 a.m. every day, watches the news, sips his coffee, very structured type person. Would he do well in a Zumba type class? I know, it's great. But he would not, I mean, I don't know. I mean, maybe he would like it, but I have a feeling he would not like the Zumba type of situation. Yeah, maybe he does. And so you can give him choices. Maybe he would be the type that, maybe he has a home gym already and you give him a solid goal. Okay, first, I want you to bench half of your weight for the next month. Next month, I want you to bench your weight. The next month, so on and so forth, to give him a tangible goal that he can reach, which may be better for that type of patient. Or let's just say you have a patient who doesn't have access to a gym, doesn't have a smartphone, doesn't have a car, it's not safe to walk in their neighborhood, all of those unfortunate limitations. Then what you can do is use this type of website, which I'll get into, where they're doing more but just body weight exercises. And you can actually print off prescribed exercises for them. As an example, just doing squats inside their living room or their room, but really being specific on how many and how long should you do it for. And, don't just say, oh, just do 100 a day. No, no, no. Do like, you need to do 50 within 15 minutes. It just needs to be very specific type of prescription. So going into this website, this is a free resource. And it seems like a lot of physical therapists use it, but as a provider, you can definitely use it as well. There is a free account, which is one I just made, and you can just make your own account, or you can do the subscription one. And I think the only main difference is the subscription one. I think you can create your own favorites and you can print off a lot at one time versus the free one. You may just have to recreate an exercise every single time and print off each one individually. But it's very easy to use. This is just a screenshot of one of the examples, but there's so many different categories. And you can even break it up into, maybe this patient already has back pain. Well, let me just give them an exercise that's going to help their back pain and help their depression. Why not knock out two birds with one stone? So, sure, if they have access to free weights, we have plenty of choices there. Or, maybe they only have an elastic band. Or maybe we need to just work more on stabilization and traction. So what's nice is you can search from there. And then whenever you find an exercise you like, and this is just all with the free account too. It has right here where you can specify how many reps, how long do you hold in between each rep, how many is considered a set, and how many should you perform each day. And even in the description over here, which I'll show this example, right there where I have the asterisks with my cursor, it's kind of frozen in the screenshot, but you can edit that whole text. So you can erase it all and create your own. You can edit it. So for instance, maybe you have an elderly person where 5 pounds is a lot, or maybe you want to start off even smaller, like 2.5. Or you already have a younger patient who's already an athlete, but wants to technically try this for his or her depression, then maybe you start off at 50 pounds. It just all depends. But you can edit this the way that you want and print it off. But I think the main idea of this from the study is that patients benefit more from having something in their hand to leave with. So if you just talk to them about, yes, Mr. Mrs. So-and-so, you need to do exercise 30 minutes a day, 5 times a week, and aerobic exercise. For one, they're going to be saying, what the heck is aerobic exercise? And then they're just going to go in one ear, out the other. But if you actually hand them a piece of paper that says, do this specifically. Next time I see you, I want to see a log that says, today I missed this day. This day I did about half of what you told me to do on the paper. The next day I did all of it. And then I went so and so forth, where it shows their adherence. It shows that they're really engaging with the prescription that you're giving them. And in a way, I feel like it shows that it's important too, because whenever the patient leaves with something in their hand, for one, it satisfies that feeling that they got something from the doctor, which in a way, sometimes I feel like that's what we do when we do prescribed medications. We're trying to give them something to go home with, but this exercise could be something that they have in their hand instead of a medication, if they choose, if that's what they want, and if that's best for the patient. Not against medication at all, but at least for this study. But I think, with patients, if they are able to have a smartphone, there's great apps that can track their activity. They don't even have to have a smartwatch or an Apple Watch. It can still track their activity just on their steps on their phone. But if they don't, then, good old fashioned pen and paper, writing it down, and just the trust system works too with your patient. But that's about it. Any questions? Oh, oh yes.
First of all,
Yes.
thank you for the shout out.
Yes. Okay.
Secondly, I think that a couple of the main points.
Yeah.
It's got to be exercise they enjoy.
Yes. Right.
And, and if they want it, yeah, it hurts.
Mm-hmm.
Or if they, especially if they hurt them, injure themselves.
Yes, that's
So
true.
you have to, especially with elderly patients, but you want to pay attention to make sure that they get into it gradually so that they don't injure them.
Definitely. Yes. That's very important. Yes.
You mentioned kind of addressing multiple concerns.
Mm.
Where maybe you have something back.
Oh yeah. True.
Something that comes to mind is if you have a patient with increased bone mineral density
Mm.
and weight bearing exercises, it's like shown to improve their growth ratio.
Right.
What if this person is really hesitant to engage in the type of activities that you're prescribing? So I know we want to pick activities that
Right.
they're interested in, but
Mhm.
the person's never touched a dumbbell in their life.
True. You know, I don't know. I think what you could do is just start off slow, maybe even before straight going into dumbbells. You can really try and improve just their strength with their own body weight first. I think that may give them the confidence to even want to even try a dumbbell. You can always send them to physical therapy too, and that can help. But I think even engaging, maybe there's a group exercise that they can join where they do like free weight training, even like a kickbox class or something where they're seeing other members, doing it and they gain confidence that way. But yeah, I mean, maybe with someone like that, I think starting off very conservative is always the best approach. Maybe just giving them that confidence. And each time you see them, congratulating them, like, oh, like maybe that would be a patient who would be interested in Tai Chi, for example, and they are just doing exercises off of YouTube, which is great. And that really improves their mobility and their balance, which helps with falls and everything too. And then they would feel more comfortable, maybe just starting off with 2.5-pound weights. And then you get the benefit of the osteoporosis too. So I don't know, but that's a good question. I don't know if you have any recommendations of what else you would do, but okay, good. No. Yeah. Okay. Good. Nice. Yes. Oh yeah. Yes. Definitely. Yes. Exactly. Oh, exactly. Right. Yes, exactly. Yeah, I'm glad you pointed that out because that's what I was trying to get across. Yes, is that yes, for some people having that community is very important and gets them out of their house, gets them engaged with other people, releases those endorphins, starts creating relationships. All that can help with depression. And it depends on the person too, because maybe you have a person who doesn't really is more introverted, doesn't really so it all depends. But yeah, thank you. I'm glad. Yes.
Resource constrained environment with our patients.
Yes.
But if you have patients that have money,
Right.
I mean, there's
Oh, yeah.
exercise business, personal patients and stuff.
Definitely.
Help motivation.
Oh, yes. Very true. And I bet they would like those to have that seen from their doctor. Like, oh, that's neat that prescription, that would help. Yes, but thank you. Oh, yes. Sorry. One more question. Oh, neat. Oh, that'd be great. Oh, that's neat. I didn't know that. Okay. That would be great. Sorry, for those on Zoom, we were talking about how Medicare can cover parts of the YMCA membership. So that would be great too. So awesome. Okay. Well, thank you. Appreciate your time.